go. Let's see. Are you already presenter? It won't let me make you presenter.
Oh.
Let me see if I can make someone else presenter first. I'm going to make David the presenter and then unpresent him.
Okay.
And now I'm going to try to make you presenter again. Yeah, there we go. All right, you should have control in just a second.
Good. Okay, this is the first patient, and I have shown a case or two like this. I think David has shown one as well, but it's maybe useful for people who don't know about this to see a case again. So this patient was transferred to our hospital for cardiogenic shock. I don't know the circumstances of that, but he's got a CRT device, he's got a big heart. So here's an image, and we can see that he has an ECMO cannula on the venous side in the right atrium, and he has a left ventricular Impella device. I don't know why they placed that via the axillary route as opposed to the usual route, but that's what he has. So when you see this combination right off the bat in a patient with that history, then the reason that they put in the left ventricular Impella device has to do with the notion of the possibility of left ventricular overdistension with the institution of peripheral AV ECMO. So you take that out of the venous system, you put it back peripherally into an artery like the femoral artery. You have a certain flow rate, you have all this blood that's coming back, it flows up the aorta, and basically it elevates left ventricular afterload. So a potential consequence of the left ventricular overload is left ventricular volume distension, with all the consequences associated potentially with that. So in order to prevent or deal with that possibility, this is intended to decompress that left ventricle. So of course you take out some blood from the left ventricle and you deposit the blood in the aorta. So we see this quite frequently now as a combo when patients are treated for cardiogenic shock in particular, in that circumstance. So here's actually an interesting thing that I noticed, and let me bring this one up here. So here we have two images done 3 days apart, and isn't it interesting that the heart literally is bigger here? Now, I know the patient is not intubated and there's not positive pressure ventilation, but I wonder if the cardiac chambers really are bigger here, including the left ventricle, because for some reason, left ventricular overdistension was present at this time. I don't know that. I don't know how to, in a sense, prove that. But maybe I'm overestimating the apparent change in the heart size, but that's just an observation that I made as well. So just the paired AV ECMO peripheral and left ventricular Impella in that circumstance.
Well, I think it's a real finding on that exam. I mean, they're pretty similar breath holds and positioning. So where, I'm sorry, so the other limb of the ECMO is in some peripheral artery, is that what you're saying?
Yes,
Okay.
Typically femoral, right?
Oh, yeah, okay.
And the blood will come in under pressure and it flows uphill, up the aorta.
Mm-hmm.
At the extreme, if you have a lot of ventricular overdistension and afterload increase, you may not even be able to open the aortic valve with ventricular contraction. And of course, that's kind of the extreme that might happen. So of course, you really need ventricular decompression to prevent that kind of phenomenon happen. Yeah.
Okay.
I think there may be published indications for the paired use of these devices in this fashion. I don't know what they are, but it has been written about in the cardiology literature, obviously. Yeah. All right. This very quick, just an interesting finding. And I'll just give you a moment to look at that, make it a bit bigger. So this down here, and this is just an observation. So we have a small worm and we have a small blob, and we can tell where it came from. We go down here, we can see some so-called intravasation, I think the word's used, or at least some of the cement has ended up in venous structures and embolized to the lung. So we've seen that before, but just in case you haven't seen that and you see these funny objects, it's just embolized material and obviously just of no consequence. This is interesting. So the context here is lung transplantation. And I first sort of came across this case on a CT that was done in this patient as an outpatient. And it said, evaluate nodules, because apparently the patient had a description of nodules in the donor lungs at the outside hospital, and they wanted to evaluate those nodules. Well, I didn't have the comparison anyway, but of course then, as an unexpected finding in this context entirely, we see that we have pneumomediastinum, we see that we have pneumoretroperitoneum, and we have pneumatosis coli in this patient, asymptomatic, outpatient. So I went back to a number of radiographs that were done earlier in the month. So this is 11:30. Here is 11:24. Not observed or reported, but we can see it here. But here, but here. This is the, oh, there's a whole bunch of them. This one is the 10th, so earlier. Some pneumatosis there. And let's see here, not there. There was another image that showed that pretty nicely there. Oh yeah, there's a whole bunch of images. Here you can see it again. So he was asymptomatic from this. It was present on multiple exams obtained earlier in the month. And this is known to occur in this context. So here are a couple of case reports, but you can find quite a bunch. So pneumatosis, 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 benign. Most of the time, of course, it turns out to be benign. In the great majority of the time, some cases, it turns out to be a significant finding. But most of the time, and not surprisingly, it's a benign finding, or at least it happens and it's entirely benign. I can't remember if we've shown cases of this before. Jeff, I think you may have.
Yeah, we've had a couple here recently, and like you said, it's long standing. And I'm still trying to wrap my head around the mechanism, but
Yep.
yeah, it does occur. And the problem is of course,
yeah,
so immunosuppressed, there's a low threshold to at least take a look with a scope.
Yeah, I mean, in this case, the patient was entirely asymptomatic, so, and had it for weeks. So, yeah. It's interesting that there seems to be a relatively big volume of air in the bowel. So one speculation is that the wall gets out of the bowel into the retroperitoneum and goes into the chest. So it starts in bowel and ends up going superiorly into the chest.
Yeah, that's what I think too.
And yeah, just an interesting case. So benign findings. Okay, this is kind of a quick case. So my question to you is, a patient with extensive unilateral left lung opacities, and I will tell you that this was discovered after a certain event during a medical procedure. So anyone want to guess what the event was and what the procedure was that resulted in unilateral multilobar opacities that I can tell you from subsequent imaging and so on cleared up. So aspiration and unilateral, left side down to play the game.
What, some sort of colonoscopy or something?
You've got it, yep. Patient aspirated during colonoscopy or in close proximity to it. Yep, exactly. That's pretty dramatic, but that's exactly it. Left side down. Yep.
Yeah, I thought maybe at first you were going to say that it was a thoracentesis for a large left effusion with re-expansion edema, but
No,
nice.
no, yeah, aspiration event, and he did fine. It was a big one. It's a lot of stuff there. So
What
yeah,
do they aspirate? Typically, they don't drink anything.
you know, I don't know exactly what happened.
Yeah.
It must just be gastric
BAL,
acid and
BAL.
secretions.
Yeah, I guess so.
Yeah.
That's well, I've not seen that one before.
Okay, those are my cases, Jeff.
Thank you. All right, who wants to go next?
I got a few, Jeff.
All right. Here you go, Peter. All you.
Okay. Can you guys see the 3 CTs here?
Yep.
Okay. So this guy, this patient is middle-aged male patient, remote history of base of tongue cancer in 2003, which was radiated back then. But he shows up with several months of feeling sick and cough. So the CT on the left is the most recent one, which I was reading most recently. You see all these kind of nodules and calcifications here. And then I look back at his prior stuff. And then the one on the right is from August. So you kind of see some kind of a pattern of calcifications here. This, when I first looked at it, I thought maybe this is metastatic calcification, but he doesn't have renal failure. So this is an infection. Any guesses, guys? The bug?
Jeez.
If it weren't for the big effusion, I like blasto. But...
What, Peter, did you say this is chronic aspiration?
No, an infection. So yeah, infection.
Can you show us the mediastinal window for the far left?
Oh yeah.
That's substantial.
It's not something. I don't think there's anything specific about it. This was ended up growing Mycobacterium fortuitum. So one of the rapidly growing Mycobacteria.
Now, interesting. That's associated with achalasia, which makes me think it's probably associated with aspiration too.
Yeah, he has been aspirating with the history of base of tongue, but they thought he got it from yard work that's in the soil.
Yeah.
And yeah, Jeff, you're right, and it's associated with lipoid pneumonia too.
Yeah, I bet it's aspiration.
So that's why I was asking. Yeah, some weird bug like mycobacterial.
Yeah, so one of the rapidly growing, but you can see how quickly it progressed. But,
Wow.
okay, this one, I think Travis showed a case of one of these recently, but this is a NF1 patient that I was reading recently, early 30s, and you can see the plexiform neurofibromas here in the wall. You scroll up to the upper mediastinum, you can see these tubular structures here. So the patient's been having, I looked at the chart, the patient's been having dysphagia for a while. So these are neurofibromas of the vagal nerves on both sides. And so here's a nice article with the anatomy. So at this level specifically, So you can kind of see the vagus nerve is runs right next to between the left carotid and left subclavian on the left, and then right adjacent to the trachea on the right here. And then this little structure right there is the phrenic nerve anteriorly, right there. So the phrenic nerve and vagus nerve.
Admit, main hospital, 7th floor, 7E, Edward.
One second, I just want to. So is this Travis, is this something similar? Was this similar to what you were showing a few weeks ago?
Yeah, the patient I showed had the large plexiform neurofibroma of the airway, but they had similar, other smaller neurofibromas of the vagus nerve.
Yeah.
And then you've got an intercostal nerve sheath tumor there as well on the right.
Yep.
Yep.
And then you got one other one. So this one, this is kind of an eye test on the chest radiograph. And probably depends on the technique here a little bit, but if you focus on
Unilateral.
What's that?
Do you have a lateral?
I do. You have the lateral, but I don't think you can see it as well on the lateral. But there's something on the midline.
Yeah, I was looking at the trachea, but I guess right.
Yeah, right there. You lose the tracheal column right there, and so that's right above slightly above the level of the aorta. So if you look here, I think the clavicles are right in the way right here. So I don't think you can see it on the lateral.
But I think it's leaning on the back of the trachea on the lateral.
On the lateral?
I thought I saw some narrowing of the airway. I think there's something going up above the aortic arch, just a little
Right
above where your arrow is, a little posterior, right?
Right there?
Yeah. But that could just be humeral head.
Yeah, because I think this right here is the humeral head, but I'm not. Yeah, not for sure there. So here's the CT. I don't think there's anything super specific, but this was kind of interesting pathology. So you can see a mass here, and it's invading into the trachea. It looks like it's obstructing the esophagus. And here's the path. So poorly differentiated carcinoma, and then those positive immunostaining for NUT1. So this was diagnosed as a nut carcinoma, midline nut carcinoma.
So that's unusual. I mean, these things occur in strange places. So a tracheal tumor, that's a nut carcinoma. Wow.
Well, they said it was arising from the mediastinum, so they called it a mediastinal mass, and then it was invading
The trachea.
Yeah. And there was nothing in the esophagus, so the esophagus is just externally compressed. Although it's hard to tell from the imaging.
Yeah.
For sure. But they went in with the endoscopy. There was nothing inside the esophagus.
Gee, that's a bad one.
And that was it.
All right, great cases, Peter. Thanks. David, you have anything this week?
I do have one case.
All right, I'll turn it over to you.
So this is a woman in her 30s with chronic lung disease that goes back to childhood. And I think you can see some rarefaction of vessels here, particularly in the right lung base here. Normal lung volume, or perhaps mild hyperinflation, but the best test for hyperinflation is flattening of the diaphragm on the lateral view, which she doesn't have. So let's just say normalish lung volume. And then on CT, she has a lot of mosaic abnormality here and tremendous rarefaction again of vessels in the black areas of the lung. So when your nice clear lung, it doesn't have enough vessels in it, it's not normal lung despite it's being so clear. The ground glassy lung is the normal lung here. So she's got a lot of air trapping here. She doesn't have much in the way of bronchial wall thickening. It's very modest. Doesn't have bronchiectasis. So disease that goes back to childhood with all of this air trapping, mosaic attenuation. I think first thing I would think of is Swire-James syndrome. So any other thoughts?
Yeah. And presumably she wasn't born prematurely, and this isn't some weird form of chronic lung disease or prematurity, but they would know that.
Well, as a matter of fact, she was very premature. She was on she was in the NICU for weeks and weeks, and she was on a ventilator up through 6 months of age and stuff like that. So this indeed, they're calling BPD. So this is adult residual of BPD. And this is about the third case I've seen that, for me, looking at it as Swire-James syndrome. Other cases have had not quite as dramatic air trapping, but lobular air trapping. Looks just like other kinds of Swire-James or, lung transplant rejection kinds of constrictive bronchiolitis. She doesn't really have an emphysematous component. So I did a little reading on this subject, and there are three forms of BPD, and according to one article in Chest, there's the asthmatic form where people have wheezing. It can be exercise induced. There is an emphysema and air trapping sort of form. And then there's, I think, a bunch of scarring and things like that. So this actually fits with the descriptions. There are very few CT scans that I've seen, though, in these articles. And somebody showed a case, was it last week or the week before, fairly recently, of BPD in an adult. And I don't recall whether it had this degree of air trapping, but I also thought that Swire-James was a good explanation for those findings in that case that somebody else showed a few weeks ago. I'm just wondering if we ought to collect these cases and publish them, because there's not that much in the CT literature of this that at least I could find on a quick search yesterday and this morning. So kind of surprising result here. One of the articles did emphasize that the old form of BPD, that's what I'd seen when I was a resident, left a lot of scarring and bullae, and the lungs look clearly messed up. They look like somebody with bad, post ARDS lung scarring, bullae, and cysts and things like that. And it's said that we don't see that as often anymore. Oxygen therapy has improved, and it's not as it doesn't lead to as much inflammation and scarring as it used to. So these days, BPD looks different from BPD in the old days. So does anybody recall that previous case? So it was just a few weeks ago of BPD. It looked like this one. I don't think there was quite as much air trapping.
No, but I think you're right. We don't see that much of it, which is kind of surprising, but maybe it's because it's so less common nowadays. But I've seen a few old cases like you described. It looks like cystic stuff, some of like the bad COVID ARDS as we've seen with the subpleural bullae.
Right.
Interesting. It might be worth pursuing that.
Yeah. So if anybody, I'd be happy to send my case to anybody who wants to collect them if we think we could put an article in the radiology literature, because I don't think there's much in radiology for the adult manifestations of BPD. It might be useful to colleagues. Okay, that's the only case I have so far.
All right, thanks. All right, I can show some. All right. So I pulled 2 additional ones in so we have some time. So these first 2 cases are just a good example of distribution. These patients have metastatic cancer. This first patient has a leiomyosarcoma. I believe it was of uterine origin, and has this interesting pattern on CT where we can see just tons of nodules. And so no question that these are metastases, but you'll notice they're studying along the fissures, along the costal pleura. There's nodules also along some of the septa, such as here. Well, that's probably an accessory fissure, but a very nice perilymphatic distribution of nodules. There's not a ton of septal lines, but this is, and for sarcomas are almost always hematogenous spread, but I think in this case we have a mix. Like there's one along a vessel there, a mix of lymphangitic spread. So this is lymphangitic, or at least lymphatic distribution metastases. I mean, you see them right there as well. I mean, almost looks sarcoid-like, other than it's not the classic craniocaudate distribution, and the history doesn't fit. So, but this is sort of an unusual distribution for sarcoma mets. But
That is.
Yeah, but it illustrates a perilymphatic pattern of nodules. And, we typically think of sarcoid, silica, col, and we don't usually talk about lymphangitic spread of tumor unless you have like a lot of septal thickening. And so it's just kind of interesting. And then the companion case I have to go with that is this is a patient with colon cancer and has the same kind of pattern of distribution. You see this perilymphatic pattern that, I mean, you could easily pass that off as sarcoid, at least at the top. You see them along the fissures, along the costal pleura. You see them along the fissures, along the interlobular septa. They are clustering and clumping together like sarcoid nodules like to do. But this one doesn't really spare the basis, and has no metastases. So 2 odd cases of very nice perilymphatic distribution mets, but without frank. I mean, there's probably carcinomatosis. It's just not what we typically think about, with more of an edematous looking lung. And with an adenocarcinoma, I find that much more likely, but for a sarcoma, it'd be really unusual.
Can you make a thin MIPS of that and see if we can see whether some of the opacities in the lobules are potentially intravascular lobular arteries lesions? It's so hard when you have so much abnormality.
Yeah, let's see, maybe make it
actually figure that out.
A little thicker here. It's hard to say.
Very hard to see.
This one here, you've got there looks like a lobule there, and you've got right in the middle. But yeah,
that's odd.
Have you guys seen intravascular colon cancer, though? I don't think I have.
Renal cell, not infrequently. The other ones, not so commonly.
Infrequently.
Yeah.
Right.
Very infrequently.
I say almost all of them are renal cell, with an occasional other tumor that randomly shows up. Okay.
But Jeff, this person,
go ahead.
Pulmonary hypertension, like that. There wasn't any pulmonary. Go with vascular obstruction.
Fusion. I don't think they did. I mean, they've been long-standing metastases, so I seriously doubt it. It never got worked up for anything other than just lung mets. But the ones along the costal pleura, I think, are pretty convincing, and along the fissures for a perilymphatic distribution. All right, changing gears. This is something I have never seen. I've seen a variant of it, so I looked into it a little bit. This patient had 2 cardiac devices placed elsewhere. And when I was a fellow, there was a trial for some device they put in the coronary sinus around the mitral annulus that had some sort of bioabsorbable thing. So they would get it around there, and then over time it would contract and improve the annulus. This is called an AccuCinch, C-I-N-C-H, that it is put in percutaneously, but it's put in within the cardiac cavity. So they anchor it around the annulus, and it's to treat, usually an intact valve, but usually some mitral regurg. And this patient also has MitraClips, which are also used to treat mitral valve disease percutaneously, but I had not seen one of these AccuCinches put in here. And I looked it up, and I mean, I hadn't seen one in a long time other than that one I saw at the fellow, but that's a different device. So I'm curious if any of you seen any of these percutaneous annuloplasty rings or devices put in recently.
Never seen one before.
Wait, which one, Jeff? That ring around the mitral?
I've seen the MitraClips. This little
Yeah.
ring here that's put in percutaneously.
Yeah, I've never seen that.
Okay, I gotta.
Presumably probably never got FDA approval. We just don't see them.
Yeah, I mean, I googled it, and you can still see the company still has a website and videos and stuff.
Oh.
Yeah, but this is what it looks like. I mean, you can imagine it almost looks like mitral annular calcification, but it's just metal, and so it anchors kind of right down there by the annulus and just follows up along it, and then these MitraClips go right on the valve itself, and I suspect tether it to the papillary muscle. So
Jeff,
okay.
is this device called the AccuCinch, or was AccuCinch the name of the old device that you saw years ago?
No, this device is called AccuCinch. I have no idea what the device I saw in 2006 was. It was in some study trial. You can see it's got these little like hooks or something where it attaches to the wall. So, well, I'm okay because I'd never seen one of these before, and we see just about everything. So that was kind of odd. All right. And
Did that patient happen to have PEs, just by the way, on the CT?
I don't know. An old CT. I didn't look too much. I don't. Well, those look like infarcts. Yeah, there's clot. There's some clot down here. Yeah.
Okay.
All right, and this last case is kind of a cool case. I don't. So this is from a different country. This patient is a minor, and you can see. I'm going to show the other finding first, but you can see up in the left upper lobe, there's these tiny little nodules. They're kind of perilymphatic, and some of them, if I change the window appropriately, are calcified. But then in the right apex, we have this other finding of this more ugly looking cavity and some dilated airways and some debris in there. So this is a case of tuberculosis, and I suspect the patient has a mild case of silicosis. And that, of course, silicosis is a risk factor for TB, and this is also a country with high rates of TB. So it's not, we don't see much silicosis here. I mean, we see it, but not that often. And to see it complicated with TB is even more rare, but that is one of the known complications. And I don't know if it's directly related to this given the low profusion of disease of silica. I'm guessing the TB was more likely just living in the wrong place at the right time. But I thought that was kind of cool because it's always taught as one of the complications besides malignancy and connective tissue disease. But this is the first time I've seen a real live case in a really long time. I've seen an old, like on hard copy film someone showed me way back when.
Some of those airways going to the opacity are full of stuff.
Yeah.
It's set up for cardiogenic spread.
Yeah, it's really thick. And there's let me zoom out. But you can see the rest of the lungs actually look pretty good. And I did look for we look typically for those dense lymph nodes, but you don't always have them. So there's small lymph nodes, but not really what you'd expect to see with silicosis. So that's what I suspected is it's very low perfusion silicosis, probably visible on a radiograph. And for the B readers out there, at most it'd be a 0-1, but probably it wouldn't even see them. But this is a nice TB. Let me make a coronal just to show those findings. But yeah, I was taken about how thick those airways are that Howard commented on right up there. And you can see the bronchiectasis and little cavitation up there. So just a nice case of TB in silica.
And the old timers used to attend our citywide chest conference every Thursdays. The octogenarians back in the 80s would always say, when you see that tracheal buckling, it's always tuberculosis. This person has some tracheal buckling.
Tracheal buckling.
Typical scarring tethers the lung in that direction.
Oh, I see what you mean. The volume loss being pulled over like.
Right. Yeah.
I don't know if that holds true anymore, but that's interesting. All righty. Well, that is what I have. Does anybody else have any other cases? Or are we going to just end a little early? Did anybody else join? Let me check. I know some people are still at RSNA, but we will resume in full next week. and then the week after, and then we'll take 2 weeks off probably for the holidays, or we'll see how people's schedules are. But all right, well, thanks for the great cases. I'll talk to everyone next week.
Bye-bye.
Bye.
Bye. Thanks, everyone.
Bye.